introduce yourself.
My name is Jim Phillips. I'm from the University of Washington. I run the Dizziness and Balance Center at the UW. We have a big balance testing service at the UW and also a multidisciplinary treatment center there. Doug chose the title. I think it's partly a joke for me because I sort of endorse profligate use of vestibular testing. We do a lot of it at the UW. I think there's a lot of benefit actually to be derived from laboratory vestibular testing. Vestibular patients tend to be very difficult patients. They have a lot of problems. Many of those problems are not surgically tractable, and the treatment strategies are perhaps not optimal for many of them. Vestibular testing takes a long time, but it's well tolerated, and these patients actually get to spend time with a provider for maybe 3 hours, and actually these tests are well tolerated. And so this person can be kind of a patient, if you select the technician or the provider carefully, this person can be kind of a patient advocate. They can listen to the patient's problems. They can talk about vestibular disorders in general. They have to be careful not to go beyond their scope of practice, but at the same time, it provides a benefit in that the patients feel heard, and these patients require a lot of time. This talk was longer, so I'll just cut through some of these slides. Vestibular disorders are really common. They're very disabling. They cost a lot of money to treat, and their prevalence increases with age. The take-home of this slide is basically that when patients come into a primary care setting and they're complaining of vertigo, say, or something like that, the majority of them, actually, the largest group of them will have benign positional vertigo. They'll be diagnosed either in the primary care clinic or the first time they come to see an otolaryngologist with a Dix Hall Pike or a supine roll test or something like that. They will be successfully treated with an office procedure, and they will not get vestibular testing. So a large group of patients are never going to have access to these wonderful tools that we have in the laboratory. And the other category here in the Brandt 1991 study includes things like parallel fistula, superior canal dehiscence, ototoxicity, motion intolerance, migraine, vascular loop syndrome, labyrinthine concussion, and so on. And these patients typically come into the laboratory with a working diagnosis of dizziness, giddiness. So people have sort of thrown up their hands. They don't know exactly what is going on. And they want to explore these things more carefully with the sophisticated testing that we have access to in the lab. For pediatric referrals, I run a service at Children's Hospital as well as at the University of Washington. We see a lot of patients over there. The pediatric referrals are from otolaryngology are primarily kids with sensory neural hearing loss or their cochlear implant candidates. It's partly for medical legal reasons, but primarily because it's reassuring to the parents and to the surgeons to document the fact that these patients have or don't have good vestibular function in the ear that they're going to be implanting with a cochlear implant. And certainly for sensory neural hearing loss, patients with profound sensory neural hearing loss, it's important to determine early on whether a patient has the potential for Usher's disease. That is to say, they have bilateral vestibular areflexia, which is characteristic of Usher's type 1. You won't be able to document the retinal findings until later in life. And so it's very useful to do this and the genetic testing, although the genetic testing doesn't capture all Usher's, so that you can provide adequate counseling to these patients and suggest perhaps that a cochlear implant would be important maybe for their child because they're going to lose the ability to utilize vision as a compensatory strategy for their hearing loss. Vestibular tests are problematic. Most of the tests of vestibular function rely on peripheral and central processing of vestibular information through basic reflexes that you can study in the lab. And most of them, in fact, look at the vestibulo-ocular reflex, but there are vestibulo-colic reflexes, which are utilized more frequently now in vestibular testing in the laboratory with the VEMP test specifically. And then vestibulospinal reflexes are, of course, evaluated, at least in part, when you're doing platform posturography. Of course, patient complaints are often related to other things like autonomic function or perceptual and cognitive function. People come in and they say, well, I'm foggy-headed or whatever. We don't really touch these in the vestibular lab. And in fact, there's some evidence that different sets of vestibular afferents, different structures, even within the vestibular nuclei, are responsible for processing these other inputs. And so we miss a lot of things, I'm sure, with the vestibular tests that we do. Another problematic feature of most vestibular testing is that it's behavioral testing. And that means that the central nervous system has to process all of these inputs before it produces a behavioral output that you can measure in the laboratory. Now, not all tests are like that. Again, the vestibular evoked myogenic potential test is an evoked potential test and doesn't really require an overt behavior. But the central nervous system is doing lots of things to these signals. It's relaying the sensory information from the periphery. It combines information from several vestibular organs, and many of our tests are organ specific. So that the end organ, say, is the lateral canal, and that's what you're evaluating, and the rest of the end organs are not touched by, say, a typical caloric test. It combines information from several sensory modalities, most notably vestibular, visual, and somatosensory information. It combines information about active and intended movement. And a big problem here is that a lot of the tests that are being developed now for clinical testing without the use of the laboratory tests and sophisticated technologies or expensive large rotators and things like that are head-on trunk rotation tests. And there's a lot of nuchal afferent input that's created by that kind of test. And if somebody's generating their own head movements, they also have information that they can utilize to generate eye movements in response to that. And then essentially what the central nervous system does is it extracts and transforms useful information. And one of the tasks that it's involved in is to maintain the integrity of that information in the face of a vestibular loss. And so vestibular problems sort of cover their tracks. Vestibular laboratory testing puts people in an environment where you can uncover the problem that they have. It might be more challenging in a clinic room. And then balance tests combine vestibular testing with an evaluation of other things, essentially visual contributions to balance, kinesthetic inputs to balance, and so forth. They're not localizing so much, but there's great utility for the large number of patients that you will see who will be referred to another service like rehab for vestibular rehabilitation. They really like these tests and tools, and if you buy the right device, for example, the Smart Equitest can be utilized both for diagnostic testing and also for treatment. So it's, even though it occupies a lot of space, the rehab folks can use it a lot of the time, and then you can use it for diagnostic procedures, maybe a couple of hours a day or 3 hours a day. What are the basic tests of vestibular function? Everybody does ENG or VNG, right? That's 99% of the patients that come to our service get it. Evaluation of saccades, gaze holding, smooth pursuit, optokinetic nystagmus, and positional tests. A lot of these are thought of as being central tests, right? They test central function. And really, they're testing basic reflex pathways, some of which utilize structures that are in common with the structures that process vestibular information. Some of them, not so much, like saccades. They're nearest neighbors to structures that are responsible for processing vestibular information. And some of these tests are important for isolating a lesion in a certain part of the neuroaxis, and some of these tests are not as localizing. The key here is that all of these tests define oculomotor function, and oculomotor function is going to be the dependent measure for a lot of the tests that you're doing, for example, calorics, when you're directly evaluating vestibular function. So it's important, for example, to know that the machinery that processes the vestibular information that you're going to be assessing is intact, independent of the utility of these tests for defining a site of lesion, that sort of thing. So we do all of these tests, and they are, of course, reimbursable, except for saccades. All of the rest of the tests are reimbursable, and they're reimbursable in a combined code, basic vestibular testing. ENG, VNG, VHIT. 99% of patients get positioning tests in the laboratory. And that's things like Dix-Hallpike test and barrel roll or supine roll test. The importance of this here is it can document sometimes a nystagmus that's a little bit difficult to see. Or you can be fooled, I think, sometimes into thinking that you have a rotary nystagmus when in fact you don't, or vice versa when you're doing clinical testing. So the laboratory is useful in this regard. Also, head thrust testing, VHIT, that provides a quantifiable measure of the response to a head thrust, which of course provides you with a wonderful clinical sign usually, which is a corrective saccade to reestablish fixation when you thrust the head. The problem, of course, with that is that there is evidence that people generate these sort of covert correctives during the head thrust itself, and so actually measuring the gain of the VOR during the head thrust is useful. Also, this provides you with an ability to test in canal planes the head thrust. And so you can assess then all of the different canals using the head thrust test, and you have a quantitative record, essentially, of the function of these rotational end organs. Head heave testing is also done in our laboratory, and head heave testing is the otolith organ analog of the head thrust test. So instead of using a rotational stimulus, you use a linear acceleration stimulus. And they like it at Hopkins. We use it. Other places find it extremely difficult to do. So you just grab onto somebody's head. Actually, a lot of times you have a jig, but you grab onto somebody's head and you just jerk it sideways. So it's a linear acceleration, yeah. And it's best to have a near stimulus when you're doing that to fixate. Let's see. Caloric tests, obviously that's the gold standard for vestibular assessment. There are a variety of different kinds of caloric tests. Most of our patients get sequential bithermal irrigation testing. That's 85% of patients. And actually, the vast majority of our patients get irrigation with air. And the reason for that is that it's well tolerated. It's also, in our lab, been a slow process getting our fluid irrigator back into the clinic. So, but air calorics work fine. The problem, of course, is that your definition of a deficit has to be expanded quite a bit because they're far more variable than is a fluid irrigation. The ice water irrigation is used in a small percentage of patients where you suspect vestibular irreflexia, and it's a way of confirming the results of air irrigation. Prolonged monothermal irrigation is used in some centers that really like in Iowa, for example, where it was developed, I think. And it's a way of looking to see whether you have a central lesion as opposed to a peripheral lesion using a caloric test. There are a number of different tests that are really specialty tests and are utilized when you think you have either a fistula or a dehiscence. One is called VNG fistula testing, and that's, of course, putting pressure pulses into the external ear canal and looking to see if you evoke either a nystagmus or a consistent eye movement. Tullio testing, same thing, but with loud tones, tone bursts, and VNG hyperventilation, or tones rather, and VNG hyperventilation test. That's used very rarely in our service. It's supposed to have some utility in unearthing sort of occult central vestibular problems and even problems with the vestibular nerve. The vast majority of people who have a hyperventilation test will have a downbeating nystagmus. So it has to be a nystagmus that's a little bit profound, and the best thing is to see one that's lateral or a horizontal nystagmus, not a vertical nystagmus, not a vertical downbeat nystagmus. About 50% of normal patients will have some sort of downbeating nystagmus with a hyperventilation test. Dynamic visual acuity testing is a little bit useful as if you have a computerized version of this test as a lateralizing test. The nice thing is it's a functional measure, so the vestibular rehab folks will appreciate it when you can provide this for them, and this is one of the things that they can train in people and they can reevaluate later. The same equipment that's used for dynamic visual acuity testing can be used for retraining, can be used for VOR retraining. And so that, again, is sort of a dual purpose. It's a dual purpose test. It's not reimbursable. There is no code for it. The training, there's a code for that, but not for the diagnostic testing. A lot of the rehab folks like gaze velocity testing. This is essentially the same thing as testing for dynamic visual acuity, but instead of changing the size of the optotypes, you change the velocity of the head movement. And that, again, is very useful in evaluating exactly the sort of exercises that these patients would potentially benefit from. And it's a nice follow-up measure for the rehab folks as they're working their way through treating these patients. Subjective visual vertical testing, static subjective visual vertical testing is used quite frequently in our lab. It's a nice evaluation of utricular function and also central function in patients who have chronic vestibular problems. And it doesn't take very long to do. The patient is placed in a very dark environment, and you just have a line that they have to align with subjective vertical, and the line essentially tips toward the bad ear. Gotcha. And then there are a whole host of different kinds of computerized dynamic posturography. This is a remote here in Washington State. In other places, it's considered experimental. But Medicare reimburses it here. The sensory organization test is the reimbursable part of this, and what it does is it deprives a person of a variety of different sensory inputs as they're standing on a platform that moves. And the task is don't move when the platform moves, either the floor or the walls move. There's a motor control test, which we also add to this, which is a way of assessing latencies of response. And this is a way of also assessing the biomechanics that underlie balance. And this is very useful for the vestibular rehab folks. Again, this is a non-localizing test. Adaptation testing, not so useful. Perhaps we still perform it. It's part of the basic battery, but it's a way of looking for lesions to the motor learning center. So, for example, the cerebellum, a cerebellar lesion, makes it difficult for you to adapt to a repeated stimulus, and that's what that's all about. And then there are a variety of other tests that aren't perhaps so useful. Headshake SOT is an important tool for patients who have, for example, mild TBI. If you suspect that, in fact, they have a problem, but the SOT isn't showing it, you can increase the sensitivity of SOT by having people standing on the platform and shaking their heads while they're being tested. Visual vestibular interaction testing is a way of drifting gratings and that sort of thing while people are standing. Again, it's a way of destabilizing them, and you can differentiate patients who have a mild problem from people who are intact. And then there are a couple of tests that are related to quote, fistula testing or superior canal dehiscence testing. And basically, you can either provide a pressure pulse and look for a kind of a postural Hennebert sign, or a platform Tullio test, provide loud sounds, and see if you can induce sway. These tests were actually quite, Neurocom, the company that manufactures a lot of these platforms, actually incorporated this into their test battery early on, and then walked it back because it was difficult to define a fistula in patients, as you all know. But it's coming back, actually, in the research literature because of superior canal dehiscence, which is easier to document, and it may have some utility in the detection of that. Harmonic angular rotation testing, scleral coil canal plane head thrust testing, scleral coil gaze testing. There are a lot of ways of stimulating the vestibular end organ by turning the head in canal planes or having somebody turn their head, shake their head back and forth and observing the vestibulo-ocular reflex. The scleral coil is a research technique that provides incredibly accurate eye movement measurement, but it's also incredibly invasive and costly and space sort of consumes a lot of space in the clinic. These tests aren't performed very often in our Rotational chair testing. Lots of patients in our lab get rotational chair testing, in part because we do air calorics. It's a nice confirmation. If you get a bilateral, what appears to be sort of bilateral hyperfunction with air calorics, you can go and test with the rotary chair, which is the gold standard, actually, for detecting bilateral loss. VOR suppression testing looks, of course, at central function and your ability to switch on and switch off the vestibulo-ocular reflex in a context-dependent manner. Visually enhanced VOR testing, you should be able to turn up the gain of your reflex. And velocity step testing, we just do that as part of the protocol. The difference between high acceleration tests and very, very low acceleration tests is they stress the system in different ways. And those responses actually depend on different afferent types in the vestibular, coming out of the vestibular end organ. And some things are differentially affected by things like ototoxic medication, so it's useful to have both of those kinds of information. Unilateral centrifugation testing, we do that in our lab. It's a test of utricular function. Basically, you get the chair going really fast and you slide somebody over so you have a little mini centrifuge. You align either one or the other utricle with the axis of rotation, the other one's hanging out in the breeze. The patient should feel like they're tipping, their eyes should tort, you can record that, and you also can force subjective visual vertical to tip a little bit. You can test it either way. Off-axis vertical rotation, off-vertical axis rotation, OVAR, is actually widely used in pediatric testing, surprisingly. And we have it over at Children's Hospital. Kids tolerate it quite well, adults don't. So unless you have cleaning staff on hand, it probably isn't the best tool for assessing. In this case, it's a good tool for assessing utricular and saccular function. And finally, VEMP. VEMP is very popular these days. It doesn't take up much space in the clinic. You can use technology that the audiologists already have handy in the clinic to perform this test. And it's a way of evaluating the utricle and or the saccule without sleds and the sorts of things that you use in research labs to test these end organs. So basically, you can either provide an auditory stimulus, or you can use a vibrational stimulus, or you can bang on the head with a hammer that has a trigger in it. You can do bone conduction. You can do galvanic stimulation. And as you would imagine, different stimuli actually activate different end organs or pick up, the nervous system picks up the response at different places, so the nerve as opposed to the hair cells. And it's a way of comparing and contrasting input from, if you compare ocular VEMP with cervical VEMP, you can compare and contrast the input from the saccule with the input from the utricle. And if you compare that, of course, with caloric testing, you're comparing otolith organ input with canal input. And so it's a nice way of covering all your bases. The problem with these tests are that ocular VEMPs are really small. They actually they remain fairly robust in older patients, which is not true of cervical VEMP. Cervical VEMP requires activation of the neck muscles, and that means that if you are sort of in recording from, say, sternocleidomastoid, that means if you have somebody who's kind of jowly and older, or they have a hard time holding up their head, this test doesn't work very well. And in fact, cervical VEMP actually often is absent or significantly attenuated in patients over 65 years of age, who are often the patients that you see with vestibular problems. So that's a quick run through of the different tests and some of their utility in a testing environment. I think the key thing to remember about vestibular testing is that it really is actually well tolerated by patients, and that it actually adds benefit to your service, because these are patients who often feel as though they've been sort of shortchanged by medicine. They come seeking a solution to a problem which is long-standing. They've seen lots of providers. They don't really know much at all about what's going on with them, actually, most of them. And if you give them comprehensive testing, you can provide often definition of their problem. You can't necessarily solve it. You give them motivation for the vestibular rehab that they're going to undergo. And they have an opportunity to talk to somebody for a long period of time in a setting where there really isn't much else to do except chat. And so they can explore all of the issues that they have associated with their disorder. And it benefits the testing as well, because that's an alerting stimulus, as opposed to having them count backwards, Lord only knows what else. So I think it's a good thing, actually, to incorporate into practice. Thank you very much. Have a good lunch, or I guess have a good drilling.